Go ahead. Thank you.
Okay, all right. My name is Dr. DeLon Canterbury. It's an honor to be here today. I am the president and founder of Geriatrics. We are a company focusing on helping people age in place with less medications. My mission today is to share more on the journey on how we all can critically assess whether these medications are helping us or hurting us. So we're going to give you some practical steps you can use in your day to day. More importantly, I'm here because of my grandmother. She suffered from dementia, and it has personally hit my family in caregiving for her. And I wasn't quite a pharmacist yet, but unfortunately, her dementia was worsened because she was on the wrong medication. So we'll talk more about that today. About myself a little bit. I'm kind of like the opposite of your traditional pharmacist. I help people get off of prescriptions. So it sounds a little counterintuitive, but I'll share more today about my journey and how I got into this space of aging-friendly care. And we'll dive into some of those tips and tricks you can leave with so you can start thinking a little bit critically about what your loved ones might be taking, what you might be taking, and how medications may not always be doing what they are intended. So it's an honor to be here. I'm so excited to share some of this knowledge with you all. And so tune in, strap in. If you need to take some notes, take some notes. If there are questions, you can just raise a hand and we can ask in the moment. This is your time. I want you to get all the value that you could possibly get today. All right. So I'm going to share my screen and we will start rocking and rolling. All right. This over here. Okay, make that full screen. And you guys able to see this okay?
Yes.
Perfect, perfect, perfect. All right. Of course, this presentation is strictly for health and wellness and educational purposes, so do not make any clinical changes without consulting first with your provider. For those of you also interested, we do have a TEDx talk talking on this very same topic called The Hidden Power of Deprescribing. I highly recommend all of you take a look at this if you can. It will cover some of those key questions we'll discuss on what you can use to become your own de-prescribing advocate. And we'll talk more about what that means throughout our presentation. Okay, so I started geriatrics in 2020. Noticed a cool RX in there, like a pharmacy symbol, my nerdy side came out. But I wanted people to find that pharmacists can do so much more than dispense medications. In fact, we can be one of your best kept secrets and most powerful advocates in really outlining your medications, your management, your healthcare options to consider, holistic vehicles to heal, and of course, looking for non-pharmacological strategies that have been shown to help improve life and quality of life. But I didn't always know that I would be an aging-friendly pharmacist. And so, as a company, we work with caregivers and other aging-friendly businesses to tackle the elephant in the room. Too many medications. Just by a show of hands, if it's you or a loved one, but how many of you guys are taking, say, five or more medications, right? A couple people raise their hands. Anyone taking 10 or more, or 15, or know someone taking 10 or 15, right? So a couple more hands rise up. So again, we rely on medications for almost every health condition out there. But when was the last time you've had a conversation about what to stop and when to stop a certain medication? And at least by looking in the room, I don't see too many people raise their hands. And this is far too common. We don't have a conversation on, has this medication kind of outgrown its use? And is it truly helping you age in place the best it can? So we're making sure that you're not paying for something that's contributing to any potential harm, especially for our most vulnerable population. So I want to throw some hard stats out here. In the US alone, people over 65, about a 750 of them are hospitalized just because of a medication, just because of a harmful side effect or an interaction. Okay. Yet, almost all of us are using about 80% of treatments involve some type of prescription. But only 13% of those prescribers actually consult with a pharmacist before they send over that prescription. Okay. And on average, we're seeing people take between 12 and 18 medications. And yet, we have a growing population with more and more older adults, more and more caregivers who don't have resources to navigate this. And yet we have less and less clinicians trained to be aging friendly in how we look at the medication list. So we're going to dive into why this is a growing problem and see, what's on the pipeline for us. So got to get a little personal. Before I, got into this space, I worked at Walgreens as your local community pharmacist. I was a pharmacy manager for going on 3 or 4 years. I really enjoyed the aspect of connecting with people and being trusted. And a lot of these pictures you'll see, I found my joy from being in community settings. Like I enjoy doing career days, teaching kids about over-the-counter meds, doing HIV and AIDS walks, and of course, doing other types of career days for middle schoolers. But I soon learned the unfortunate business side of healthcare. And that was the piece that you don't really get taught of in school. Understanding insurance, copays, prior authorizations, denials, all these little things that come up. And while here I am working at the pharmacy counter, essentially telling people, 60, 70 years old, hey, look, it looks like the copay on your eye drops is $300 just because you're in the Medicare donut hole back then. And it was a bit disheartening having to see people torn between paying an electric bill, paying a light bill, even paying for the gas to get to the pharmacy to now choose whether they go blind or have worsening glaucoma or whatever. But that was my job. And it was a bit soul crushing to essentially be a part of this process of basically profit for the company versus the health and well-being of the person in front of me. And that's what got me down this road of feeling a bit unaligned, misaligned in my work. I felt a bit depressed. I felt very angry that my job was to essentially fill as many medications as fast as possible and give as many shots as fast as possible just to make profit margins work when we were missing the mark and really looking at the holistic side of the person in front of you, the caregiver, the person who's navigating this maze, who doesn't have much support, and you end up just feeling a bit as if you're an imposter. And that's how I felt in my initial parts of my career. Here I am, a part of a model where I am reimbursed based on how many shots I give, how many pills I fill, how fast do I do it, and did I do it in 15 minutes or less, and it made you smile. I didn't get a degree to become another Burger King for drugs. Like that wasn't my job, was to be a fast food. Like my job was to help people, right? And that's where that internal depression led to anger, and that eventually led to action, where I ended up doing something different. I don't want to be a part of this overprescribing pandemic. I mean, how many of you guys alone maybe have watched TV yesterday or today? And there's some ad about a new drug, singing and dancing on the beach, making people seem happy. And it's all nonsense. And a million of miles a minute, all these little side effects are said at the end. It's a game and it's a billion-dollar industry intended to keep those to make more money. And I understand it. But we need drugs. There are points of the day where we know that medications have prolonged life, but we don't look and see, hey, is this the right medicine for me? Or is this the right medicine just because your book says everyone should be on this? And there isn't that personalization around the medicines or how we treat things culturally or even socially. So what did I do? I had to do something different. Now it's going into 2019, about to enter 2020. And I said, you know what, DeLon, I quit. I don't want to do Walgreens anymore. I want to get back to my roots. And I started volunteering. I started a new position at the poison control in Charlotte. Ended up being a poison control pharmacist. Super cool.
Right.
I ended up, unfortunately, getting fired 4 months into my job because I fell asleep at my desk. All right. This is during COVID, no benefits, no plan. I was livid. And I said, this is the last time I'm going to let someone else dictate my fate. And as much as I love the job, they didn't even ask how I was doing. They didn't ask what was going on. This is in the height of COVID. There was no type of empathy. And as I said, I'm going to do something different. I want to lead with empathy in mind. So that became the biggest blessing in my career because it led to me starting geriatrics full force. And while I was starting geriatrics, I became a trusted voice in the community. I started volunteering at the local nonprofit that did wellness checks for seniors with Community Health Coalition. I served as their telehealth director. It was also the height of COVID, and so I ended up being a member of the African American COVID Task Force in Durham and Raleigh, where I'm based. And all of these connections led to this trust and knowing that, hey, I can actually give valuable information that can help people in real time. And that led to the impact that we're seeing today in our growth. But the common theme of this was I was serving in my purpose more than just doing another job. And that alignment led to the creation of geriatrics and then also the impact we've had with future clients and patients who are struggling to navigate the emotional burden of feeling ignored by your doctors, feeling neglected, not knowing who to turn to, feeling rushed out of the pharmacy because you're in drive-through for so long. All of these social pressures, and you still have to go home and take care of your loved ones. It wasn't right. It didn't sit right with me. And it gave me that perspective that there had to be a different way pharmacists can show up for you. And so I did mention my grandmother a bit earlier as being a main driver of the creation of this company, but I wasn't quite a pharmacist yet. I was actually still an undergrad trying to get my bachelor's and figure out where I wanted to go next. But I knew I always wanted to be a pharmacist. But what happened with my grandmother is something that I think we all can resonate with. Again, given the wrong medication, and we'll talk more about what that medication was and how we were able to find out the issue. So 2020 is here. I discovered this world called prescribing. How many of you guys, by show of hands, have heard of that word or maybe know what it means?
Mm-mm. Yeah.
So no hands raised. That's okay. Great.
Mm.
That's why we're here. But I learned that essentially deprescribing is the safe removal of medications that may or may not be beneficial or helpful. That's really it. But it's done with your clinical provider on board. All right. And a pattern I started realizing when I was in the community was the patients that were in and out of the hospital were one, older, right? 65 or 70 and up. And two, they tend to have the highest number of medications, like period. And we're not talking just nine or 10, we're talking 15, 20, like
Mm.
25, lots and lots of medications. And it got me wondering, do I want to just continue to be a part of the problem and just refill them as business as usual? Or do I want to pull them to the side and say, hey, look, you can probably stop about five of these, but
Mm.
I can't tell you that because my job is to keep you on a bunch of meds. Unfortunately,
Mhm.
it's true. And I would lose business and thus lose the incentive of a bonus if I'm telling my patients the real truth behind the more meds you are on, the higher the risk of potential harm. And we
Mhm.
did not learn this in school. I did not learn the word deprescribing in school at all. I learned it in the community and then eventually becoming a geriatric or aging friendly pharmacist there was a whole term that came out of nowhere, and I was like, wow, I didn't realize this is actually a growing field of science and research. And this is where the future of aging is dependent on having key people become these deprescribing champions. Okay. So, just so you know, we can help anyone anywhere in the country. We're a remote service. It's all telehealth based. As long as you got a phone or internet, we can do a review on anyone's prescriptions and at least give you the lowdown on if this is really beneficial or are there some red flags that we have to address. So we provide concierge medicine. We work with families. We work with your doctors. We continue that care to make sure there's no gaps. And during the pandemic, I actually gave my sister here a COVID shot. I was able to give her first COVID shot, so it was pretty cool to kind of pay
Mm.
it forward. But that was all while building my business and still serving as a community member. And then this picture actually was actually in where was that at? That was actually in San Diego. All right, guys. So I love to give case presentations. So I want to share an example of how we can address this together. Yeah, if anything resonates with you, please let me know, drop it out. But we got an 80-year-old woman who comes today with her caregiver who is presenting with us with chronic constipation, increased confusion, worsened memory loss, irritability, no energy, and dry mouth. The daughter unfortunately describes her as being a walking zombie over the past few months, just sitting in the room, not very responsive to communication or triggers. She's not really finding joy in the things that she likes. And she's been living with her daughter since her husband died in the last few years. So, I want to show you guys what the medication list is and give you a feel for what this person might be on. Now, looking a bit closely, you'll see that some medications may or may not be taken, but for some of you who might be familiar, I'd love for you to kind of think as if this was your loved one and you're seeing this med list, what are questions that you have? Where do you want to start? What are some patterns we're noticing in some of the descriptions of this case?
That's
And
been Andrea.
we can work together, guys. Don't be shy. We know we're all friends here, you know.
Allergy to question 8.
Yeah.
Oh, side effects. What are the side effects of these medications?
What are the side effects of some of these medications? That's a great question, right? She's coming to us with confusion, constipation, all of these issues. Could we tie all of these issues to any medication here? Or maybe even a combination of medications, right? So excellent, excellent thought. Anything else? What else jumps out at you? Are there any meds that look familiar?
Well, question is like having taken all of those medications, then it creating another chemical from the effect of them combining with one another, creating
Mm,
could be causing these issues that she's having because it's too many medications take time and then their chemical effect together, like scientifically, they're meshing together.
mm,
What about
thank
that?
you. Yeah. So trying to get to the nitty-gritty of are these medications causing added harm in the how they work? And is there a new chemical or new prop or new something developed because you're using multiple different meds that are not working well together? Excellent question. And it's an excellent perspective that pharmacists are naturally trained to address and identify, which is why I like to encourage caregivers to have an awesome relationship with your pharmacist. And I know it could be difficult, but I love the mom and pop pharmacies. If you have one local, try to support them. They tend to go the extra mile to ensure you're getting quality and not just quantity. So it's a great perspective, and we're going to dive into what that looks like and how I can kind of decipher what's going on here. Any other thoughts, right? Any patterns we're seeing?
Well, I see 2 medicines for dementia and 2 medicines for anxiety. Anxiety, oh,
Yeah.
3 medicines for anxiety, huh?
Yeah, so you're seeing some medications for anxiety, and it makes you kind of wonder, is her anxiety being well managed? Are they effective? Are these medications worsening the anxiety? These are good probing questions we want to ask. Now, again, she's being described as a walking zombie, meaning she's probably a bit sedated, a bit tired, confused, a bit out of it. She may not be able to tell us she's anxious right now, and she does have mild dementia. But that is a key question we should raise is, are these anxiety meds a part of the problem? And as you identified, there's a medicine on here called clonazepam, 2 milligrams, and she uses it every night. She uses it for anxiety and sleep. How many of you all have heard of this medication or heard of it being used for anxiety?
Oh, there was one hand in the room. Actually, you can't see it, but there was one
Okay,
hand.
yeah, I see it. So it's a great observation, right? Clonazepam is one of those medications that can cause sedation and fatigue and even can increase your falls risk. And it's often used inappropriately for sleep and anxiety. Now, if you're middle-aged, 20 and 30s, and you have a panic attack, it's excellent to help you for those really severe panic attacks in the moment. I think some of y'all have heard of the phrase, hey, take a chill pill, right? That's what this medication is. It's essentially that class of medication. Now, when you're essentially, middle age, you're dealing with it, great. You can use it acutely. It can build a bit of a tolerance and you can get a bit dependent on it over time. But in older adults, the reason why medications can be very sensitive is because our bodies are, quite frankly, different. The way they break medications down are different. The way they hang around longer is much pronounced. The way it's cleared, much more pronounced. So all of these effects means the side effect profile that we see in your 30s and 40s can vary wildly when you hit 65 and up to our more seasoned age. And when this happens, the drugs work completely differently. And so drugs like clonazepam, the chill pill, can actually prove to be more harmful, especially in people that are suffering with brain changes and cognitive impairment. It has been shown to worsen confusion and mentation, etc., while also increasing falls risks. So, first and foremost, it's a great call out. It's a medication that, frankly, should not be used in people 65 and up. All right. It's what we call a medication on the potentially inappropriate list from our aging-friendly geriatricians and pharmacists. They've created a guideline that says, hey, we want to generally avoid this medicine because the evidence tells us there's more harm than good. All right. Does that make sense, guys?
Yes.
Now, you may not have to know all this stuff up front. That's fine. But there is a reference. It's called the beers list. I love beer. If you want to buy me one later, that's great. But the beers list literally tells you all of this stuff. It's freely accessible. You can Google American Geriatric Society beers list or beers criteria. It can tell you all the medications that they think are more harmful than helpful. But I promise you guys, you are still going to see tons of these types of medicines used inappropriately in this population. But they'll say it's for anxiety, or they'll say it's for dementia, or they'll say it's for behaviors. But you have to really get below that and see, hey, look, clinically, is it actually for that? Is there evidence for that? Or are you just pulling my chain and trying to make my mom knock out? It happens. And that's where I come in and help providers and families manage the two. Okay. So clonazepam is something I have to really harp on. It's a class of meds called benzodiazepines or benzos, like Xanax, Valium, the chill pills. They're all chill pills. So it's one that I really would want to stop if I have a patient presenting with confusion. Okay. Anything else jump out at you guys Any meds look familiar? I know amlodipine, we know that's a blood pressure medicine, right? Sound good? We got aspirin. She's on Seroquel, quetiapine, a couple of allergy meds. Look at number 8. She's on gabapentin, and she takes it for nerve pain, but it doesn't help her nerve pain at all. So why is she taking it if it's not helping, right? So these are
Right.
the type of questions we want to bring up, and eventually we came up with a plan to stop that medication. All right. So I got some other bad news,
There's one
unfortunately.
more comment in the chat. It says, can some of these meds be reduced by diet and nutrition?
Can some of these meds be reduced by diet and nutrition? Potentially. And I would say the big ones we can see around that would probably fall under blood pressure management. If we're walking, if we're having some weight loss, if we're staying hydrated, if we're minimizing dietary salt intake, those all can lead to more pronounced effects than our own blood pressure meds. So that could potentially help her get off of the lisinopril that she's on and or the amlodipine that she's on as well. She's also on lovastatin, which is a cholesterol medication. Are you guys familiar with cholesterol meds?
Yeah,
Yeah, yeah, right. Like the atorvastatin, rosuvastatin, Crestor, or whatever. So yeah, now depending on why you're on it, some people use it just for cholesterol. Some people use it to prevent a heart attack or a stroke. If she's had no heart attack or stroke history, you can manage cholesterol with dietary changes as well. More fibrous foods, avoiding processed, cheeses. Depends on your type of form of cheese. But having the Mediterranean diet is a great way to hit blood pressure goals, and having healthy fats is a great way to hit that cholesterol lowering effect too. Okay? So yes, your question's totally on point. Some meds you can do away with by changing lifestyle and diet.
experience having clients that have the lovastatin, and the lovastatin tends to also deteriorate the ability, weakening of the legs and veins in the legs. And so when
Mhm.
that happens, and you mention that to the doctor, do they take them off of it completely? Is there a replacement in reference to the repercussions of what is happening to them? What do they do then? I mean, what is the suggestion for that?
Yeah, it's a great question. Thank you. And it does come up fairly often. So statins kind of have this bad rap of causing muscle pains, muscle aches, and when it's at a higher doses, it can even cause a more severe form of that. It is a known side effect. I think it's seen to be, I don't know, 5 to 10% of people who take it may experience those issues. There are a couple of things you can do. But first and foremost, my question is this absolutely necessary for me to live? That's the first question you should ask of every single medication. Is it vital for me to live? And is it important for my quality of life? All right. Of course, some providers may lean towards yes, oh, everything is. But you want to actually ask further and say, what's the literature? Why am I on this? Is it because of my family history? Is it because of this? And to challenge it, what can I do naturally to get off of this medicine, i.e., the exercise, changing my diet, blah, blah, blah. So once you've already had that convo, now we can start talking about the drugs and say, well, maybe lovastatin can be lowered to another dose, or maybe it's switched to another statin that doesn't have as much of a muscle cramp risk. And there are different statins that can have a better profile for that. Um, or maybe we can use another drug altogether and avoid a statin and put you on something else that might be less effective, but can still work. So all these options can be discussed in a shared decision matter. Okay. But if you're having problems, I encourage you to always try to communicate those issues directly to your provider. I think it helps to at least get a pharmacist perspective first to just kind of glance and tell me, hey, can I get a pulse check on what's going on? But any issue, cramp, side effect, diarrhea, name those side effects And if you suspect it's related to a medicine, tell them what that is. All right. That's one of the first steps to getting the meds
Right.
changed and getting better options for you. Great question. So, any other thoughts, guys? It's been good questions. So, unfortunately, this is only the first part of the list. She actually was taking much more. She was on 30 plus medications. She had a number of over-the-counter meds and was self-medicating because she was having difficulty with sleep. So she found herself using a bunch of meds that had Benadryl in it or Tylenol PM. Um, and all of this added Benadryl plus some of the other side effects. We were able to determine that she had about 6 or 7 prescriptions plus over-the-counter meds that were contributing to a lot of the confusion and the side effects that she was experiencing. Um, so there's a reason why we try to avoid Benadryl as a sleep aid for people with brain change, and it's because it blocks a certain chemical in the brain that we associate with memory. Okay? That chemical is called acetylcholine. So some of these medications on here block how that works completely. And when you block it, like Benadryl does, it can worsen confusion, it can worsen falls. And it's generally advised to avoid in anyone with any type of dementia. Unfortunately, guys, a lot of your doctors do not know this. A lot of them are not aware of this property. I would say most geriatricians are familiar with this and are comfortable in spotting this, but your average person isn't going to really know this or look for this because they just barely had the time to look at this holistically. But that became one of the main issues in this case, the confusion, the constipation, the worsened memory, the irritability, all of these side effects went away once we were able to hone in, use our pharmacist expertise, and minimize this list from 30 plus meds to just 8 medications in a few weeks' time. All right. Now, I'll be honest. I'm out of North Carolina. The average cost for a memory care senior living facility out here is going to be between $7,000 to $12,000 a month. Okay. In LA, it might be significantly higher. You guys can tell me. But we were able to keep this woman from being forced into a memory care unit just because of this one consultation. All right. But by my math, it's been about 7 years since that happened. This is well over $500,000 we've saved this family from just having one medication review with the perspective of less is more. She had 6 to 7 different doctors. She had a PCP who was ready to make some changes. But guess what? This has been going on for years. This didn't happen overnight. This took years and years and years of just doing the same thing and no one critically advocating for her.
Right.
How much pain has this caregiver had to go through just to find out now that, this could have been all prevented? It truly could have. And I don't want this to happen to anyone else. And to be frank, this is exactly what happened to my grandmother. She was put on an antipsychotic. You're going to often see a medicine called quetiapine or Seroquel, and it's supposed to be used for behaviors, as they say, but it's also one of those gray areas in dementia where, because there aren't many options, we just try it to see if it helps with issues. But really, and this is where Natalie Roseman's expertise is we have to try everything non-pharmacological first, redirecting, training our caregivers to understand that there's a different approach that isn't in a pill. But that medicine is what we call an antipsychotic in our world. And the use of that medication, and although sometimes it can be helpful, generally isn't advised. And it has a black box warning from the FDA, right? Straight on the label, it says, do not use in patients with dementia suffering from behavioral or psychological disorders, i.e., bad behaviors that they want to call it. And To me, a behavior is simply an unmet need that has not been identified. They're trying to communicate a need, but we aren't speaking the same language. And this is, again, where Natalie's forte and what always provides us with support from you all today. But knowing this detail, uh, that's a medication that we try to avoid in this population. And that was a similar medication that my grandmother was on that led to her wandering and her irritability. And it wasn't until my mom went to the pharmacy and complained about all the side effects that the pharmacist stopped what they were doing and advocated for de-prescribing. And she eventually got off the medicine and in just a couple of weeks got better and lived to see the beautiful age of 90 years old. All right.
Wow.
So that is the reason why I'm here today. That is the power of de-prescribing. That's the power that pharmacists have, but are just in a different setting. But we want to do this. And that's where I created geriatrics, was to give you guys the truth on what these meds may or may not be doing. But that's the power that really starts with the caregiver. This would have gone nowhere if a caregiver didn't reach out and say, I think it's the meds, but I just don't know how it is. We were able to see it plain as day, but you guys have 10 other things to do. Let us do that for you and help you out. Any questions about this so far? Excellent, excellent. So again, we provide a number of resources to help people figure things out. One other tool we like to advocate for is genetic testing. You guys are very lucky. You're in one of the few states where Medi-Cal completely covers genetic testing. So if you have a loved one pretty much on any type of antidepressant or antipsychotic, or really any medicine that they've had a poor effect with, or they've tried and they're still trying to add on more, you can advocate for Medi-Cal to cover this genetic testing. And it's a way to check your DNA to see how your medications interact with your body. And it gets down to the nitty-gritty, okay? A lot of these meds that we have today, they're grandfathered in from decades and decades of us using them in the general population. But they weren't always studied in Black populations or Latino populations. We just kind of use the same meds for everybody. Genetic testing to me is one of those equalizers that looks at your body to see, oh, no wonder you didn't do well on that codeine for your pain, or that antidepressant for your mood. No wonder you didn't do well, because your body just can't break it down or you can't respond to it. That's the power of genetic testing. So I highly advocate for this. If you have someone who's been failing a number of therapies, ask for genetic testing for medications, not Ancestry and Me, but for your medications. And you'll get a different perspective on how those drugs may be helping you. So I'll be very frank. I never saw myself becoming this leading voice of de-prescribing at all. I didn't even see myself owning a business, but it's become a calling and it's become a passion to empower everyone today and everyone that I meet on how we can think differently about treating medications as a whole. So we've built workshops around this. We've trained people on this. We've trained clinicians on how to do this as well. But it comes from a place of, in order for us to really move the needle on aging-friendly care, we have to use social workers, we have to use pharmacists, we have to use a different model that addresses these care needs. Because what I'm doing is great, but it's only a small piece of the puzzle. There are so many other factors at play here. Having access, having resources, using community partnerships like we all have today here today. Those are the pieces that give you that continuity and that confidence to not go it alone. All right. So again, this was never in the stars. I just wanted people to know that pharmacists can show up way differently than you think. And if you don't have a relationship with one, start making one today. If you got a little bit of extra bagels, bring some donuts, get to know your pharmacist. They're busy. They're dealing with all the crap that they have to deal with. And I was there. But befriend them and let them kind of tell you the real truth of what they think when they look at some of these meds. Because I promise you, we don't want you on all this stuff. We're just doing what we kind of have to do. But I had to leave that way of thinking and create something that gave me the joy and I could sleep at night and know that my advocacy helped you get your grandmother back. It helped you get your loved one back, your spouse back. That's a joy that's priceless. Okay. And it's why I just love doing what I do. And yes, everyone needs a pharmacist. Who's this guy? That's me. We all need a pharmacist, right? And it doesn't matter where you are. So again, we mentioned deprescribing is the safe removal and tapering of the medicine that may not be helpful for you. There are a lot of buzzwords in here like polypharmacy, overprescribing, etc. But we define polypharmacy as essentially taking five or more meds. It doesn't mean that all five of those meds are bad or problematic. It simply means that when people have med lists greater than five, the associations of studies tell us that there's a higher risk of potential issues. That's just all it is. Doesn't mean it will cause issues. It just means there's a higher risk for people 65 and up of having complications from those medications. So that's why we shoot to have your med list as small as possible. And yes, this does include over-the-counters and supplements and vitamins as well. We want to make sure those are safe for you. So medicines aren't always the answers because one, we don't really lead with lifestyle changes. A lot of my work is giving people the access to other providers that specialize in health coaching, or maybe you need a physical trainer or a nutritionist or someone else to hit some of those alternative approaches. But I promise you, meds are not the answer all the time. Like for most people, yes, we're gonna need a couple of them to live and such, but as the answer for everything, no. And the evidence tells us the longer your med list is, the higher the risk of potential mortality and morbidity, and we don't want that. So all of you should have the bedrock of knowing, do I still need to take this? Does my loved one still need to take this? And at every visit, at every appointment, make this a priority conversation. All right. Is it
Yeah.
vital for me to live? And
Mhm.
or is it important for my quality of life? If it doesn't hit those two, you probably may not need that medicine. All right. And yes, you should also ask, what are the risks of me stopping a particular medication? Are there withdrawal effects? Are there side effects? What are the risks? What are the pros and cons? Everything should be done as a team-based effort between you, your provider, and your loved one. I gotta show my granny because she's the reason I'm here. And seeing what she went through. Mildred, was dealing with this issue, and my mom was a teacher, my dad an accountant. They were trying to navigate all this stuff. Her behaviors were so bad, they had to move her from New York, where I was born, to Atlanta, where I grew up. And now we've got a full-time teacher and my dad, a full-time accountant, trying to navigate three kids and figure out the dementia she had, childproofing the home, trying to make sure she's safe. We found out that similar to the Seroquel, she was on a medication that was inappropriate, and we got it stopped. She lived to see the beautiful year of 90 years old, and she died on my very last day of pharmacy school.
Oh,
So she
wow.
lived a full, happy life, but she didn't live essentially unhappy and confused and irritated. She lived with her wits about her, with a smile on her face. She had her memory back. Yes, it was mild dementia, but it wasn't severe. And she remembered us, and she was joking, and she was jovial. And it left such a profound mark for us to come together to go see her lived this beautiful life of 90 and then eventually die that year. And it to me was a sign and testament to what that pharmacist did to me and why I want to be that pharmacist for you today.
Thank you.
Of course, of course. Another example, and this is something that someone kind of mentioned, was, sometimes people are using drug A to treat blood pressure. Now that blood pressure medicine causes a side effect. So prescribing cascades happen when a side effect is misinterpreted as a brand new health condition. So say I put you on, some amlodipine. This is a common example. I put you on amlodipine for your blood pressure. People don't often realize that amlodipine can sometimes cause feet swelling, right? So instead of me seeing it as a new or a side effect, the provider is now going to give you a diuretic, a water pill to treat your feet swelling. So that's kind of where the mistake starts. But now I'm giving you another med to treat your feet swelling, and now you got that feet swelling and your fluid collection. I'm now giving you another med to treat the increased urination from you being on a water pill. And now drug B comes into picture, drug C. So now I gave you another med to treat your overactive bladder, and the saga continues. All right. This is what we call a prescribing cascade. So essentially, one drug leads to another drug being added, leads to another drug being added without someone saying, let's stop and see where the cause is. So rather than going down this rabbit hole, they could have just simply switched amlodipine to another blood pressure med, and all the other issues could subside. And this is what I see all the time. And all the cases are just a little bit of chasing the dragon with different issues. Okay. I don't want you guys to fall for that. So there are a couple clinical resources. I won't get into it. I do believe deprescribing.org is a great one to just mentally keep. But if you're looking through a med list, have us go through the beers list. I think, again, is a great resource. But we are researching this day in, day out. Another great one is medstopper.com. But more importantly, if you need help with this, just give us a shout. I'm going to give you my number on the screen. So you can text or call this number to book a complimentary 20-minute conversation. Check out geriatrics.org, and I'll leave it for any questions. And thank you all for your wonderful energy and participation today. Thank you.
Thank you, Dr. Canterbury. Are there any questions here in the room or online? No, that just tells you how thorough you were. I'm gonna go ahead and put your information in the chat, for those who want it like right now, even though we will send out this deck. This very
Geriatric stuff, yeah.
very creative there. Did you come up with that?
Oh, you know I did. You know I did. It was like 3 a.m. at night. It just came at me. I was like, oh, yeah, that's it. I was like, yeah. I didn't know what to call it for a while, but it was the year I was terminated in 2020, and I just came into me in the middle of the night. And actually, it was a year before that. But yeah, middle of the night, 3 a.m. download just came. I was like, yeah, put the RX in there. It's cool. I was like, all right, cool. So yeah, thank you.
Yeah, I like it. It's pretty awesome.
So we do have Dr. Canterbury's TED Talk that he talked about, that he mentioned in the beginning. And so I will send that out as well, for anybody who wants to listen to it.